Today's video is about cholecystitis. So, pathophysiology of cholecystitis is inflammation of the gallbladder, and the gallbladder holds bile, which is a digestive juice that is released into the small intestine used to digest fats. The liver is the main producer of bile, and the gallbladder over here stores that excess bile and releases that when needed. When this path here, the bile duct between the gallbladder and the small intestine, is blocked, bile becomes trapped and builds up, causing inflammation. So a lot of times surgical removal of the gallbladder is required. The cause of obstruction of the bile duct may vary. The majority of cases are caused by gallstones or calculi made of crystallized bile salts that end up getting trapped in the bile duct. Biliary sludge is the mixture of bile, cholesterol, and salt that can build up and form a blockage, and other obstructions may develop from infection, tumors, or edema from compression of the blood vessels. So whatever the cause is, if this guy is inflamed, it's bad news. So how do we find out if a patient is suffering from cholecystitis? Then there's some diagnostic testings we can use. An ultrasound is usually done first, and that's performed to visualize the inflammation and possible gallstones or blockages. If that's not enough, CT scans and MRIs can be used if those results from the ultrasound were inconclusive. Another option, according to our MedSurg textbook, is endoscopic retrograde cholangiopancreatography. It was mostly called ERCP because that was really long. Liver function tests, white blood cell count, and cerumen bilirubin is also performed. From that liver function test, AST and ALT may be elevated due to liver dysfunction in cases of obstruction, and elevated bilirubin may indicate common bile duct obstruction and liver dysfunction. So clinical manifestations of this disease: generally patients will report nausea and vomiting. They have severe right upper quadrant pain, and it tends to be worse about 2 to 4 hours after a high-fat meal, and the pain will last for a few hours. You can also see something called Murphy's sign, and this is specific to gallbladder and liver damage. This is where you press your hand or fingers up under their ribs on the right upper quadrant and then ask them to take a deep breath. If the pain is so bad that they can't even breathe in fully, that's a positive Murphy's sign. And lastly, we also see rebound tenderness, which is when you press on the right upper quadrant and then release, and the pain is actually worse with the release than with the initial pressure. They may also have loss of appetite, clay-colored stools, fever, and jaundice in severe cases due to the liver damage from the blockage. So interprofessional care that should be provided. The first thing we want to do is decrease the amount of gallbladder stimulation. This is done by making the patient NPO, nothing by mouth. If no food is coming in, then we won't be stimulating it. We can also place an NG tube to decompress the stomach. This means that not even stomach acid will be making its way into the duodenum, so now there's very, very little stimulation of the gallbladder. If they are eating, we encourage low-fat, non-gas-forming foods. We'll also give analgesics and antiemetics for their symptoms. We are focusing on treating pain, relieving nausea and vomiting, providing comfort and emotional support, maintaining fluid and electrolyte balance and nutrition, making accurate assessments, and observing for complications such as jaundice and infection. So the general treatment plan and medication used for cholecystitis, it just depends on what the cause is, but generally if gallstones are the cause of cholecystitis and the patient is having mild symptoms, extracorporeal shockwave lithotripsy can be used along with oral dissolution therapy, medicine called ursodiol, to break up the stones with high energy shock waves. The fragments can then pass through the duct into the small intestine. And ultimately, the most common course of treatment for cholecystitis is a cholecystectomy, or removal of the entire gallbladder. Since the liver is where the bile is made, the patient is still able to secrete bile, except it won't be very well regulated. It will just kind of constantly drip into the duodenum. So patients still need to eat low-fat diets, and immediately after surgery, which is usually laparoscopic, called lap chole, we want to monitor for pain and signs of infection. We want to encourage the patients to use a pillow to splint their abdomen when coughing to prevent wound dehiscence and decrease pain. Common medications used to treat gallbladder disease are analgesics, anticholinergics, fat-soluble vitamins, bile salts, antiemetics, and antibiotics. Morphine may be used initially for pain management and other various forms of narcotics. Anticholinergics such as atropine and other antispasmodics can be used to relax the smooth muscle and decrease ductal tone. And then, of course, we want to give them those vitamins since they're having a hard time absorbing, especially with being on NPO. So the nursing process would look like in a plan of care for this patient. Again, starting with that abdominal pain assessment, that's going to be huge as far as finding out what's going on to distinguish it from other gastro problems. Definitely going to want to assess those lab values and the vital signs. Again, generally they're going to present with pain, vomiting, and they're going to talk about how that happens from eating fatty foods, that abdominal tenderness, possibly jaundice, clay-colored stools, and there could be elevated liver enzymes, bilirubins, and white blood cells from their lab values. Then for a nursing diagnosis, in most cases, acute pain related to inflammation as evidenced by pain and autonomic responses, such as like increased blood pressure, things like that from that pain, is going to be a general nursing diagnosis for that. We're going to plan that the patient will be free of pain and maintain optimal diet and nutrition from the following interventions, which would be administering those medications, whether analgesics and or antibiotics. They're going to be put on NPO status, most likely, have an NG tube for suctioning. We're going to be monitoring their INO and preparing them for pre-op. We're also going to be monitoring those electrolytes and talk about avoiding those fried foods, fatty foods, anything that's spicy, those foods that were causing the patient to have these symptoms. And then we'll evaluate it by seeing if their vitals have improved, if their pain has improved, depending if they had surgery or however it was treated. We'll use the teach-back method for patient education. And some good things to include in that patient education would be diet and exercise to control weight, since obesity is often related to gallbladder issues. Avoiding those foods high in fat, like fried foods, avoiding gas-producing foods such as beans and carbonation, and then limiting or avoiding gastric irritants such as alcohol, coffee, tea, caffeine. So that's cholecystitis, and the references will be attached in my paper that's uploaded.